So Dr. Spicer trying to be all tricky here. These are my disclosures, and I do have the birthday wish again after the wine last night. I couldn't remember which talk went first this morning. I'm sorry. So again, Dr. Spicer, thinking you were tricky, you didn't really know that I actually have been an advocate for SBRT throughout my career. I participated in these guidelines for the appropriate use of SBRT in early stage lung cancer. And when one of my colleagues called SBRT snake oil, I actually was in defense of the use of SBRT in collaboration between surgeons and radiation oncologists. So I can't promise the spice and the fight that you may have gotten if Dr. Stiles and Dr. Marcogni were here. And face it, I'm debating Dr. Palma. He's so nice. I can only look bad. But I do promise to be very self-centered as a surgeon and think about what's in it for me and what's in it for surgeons, because that's really how surgeons think, isn't it? So when you go back and you look at outcomes for stereotactic body radiotherapy in early stage lung cancer, I go back to the two prospective trials from the RTOG. They're both getting a bit dated now, but I think the data still holds. That the reality is with 18 grade times 3, we get really good local tumor control. 98% in tumor control, 95% in lobe control, and even the local regional control really competes quite well with surgery above 80%. Where these fall off is in disease-free survival and overall survival, and those are not super exciting. Similarly, this was the 0813 trial looking at the central tumors, and in the higher doses where this was tolerated, you again see excellent local control, but poor disease-free and overall survival. And I really like that A curve because it shows the competing risk of death in this population. We still use SBRT primarily in patients who would not otherwise tolerate resection, and their competing risk of death is quite high. How do we tease this out? It's really challenging. But this is why it exists, because I can't operate in the majority of these patients. Let's face it, they are lovely people who many of them will have many good years of life ahead of them, but probably not if Dr. Spicer and myself get too far involved in their life. So this is the population where lung cancer exists, and therefore we have to have strategies. I love this paper. It's a National Cancer Database analysis looking at the utilization of SBRT from 2004 to 2017. And we can see that it took the treatment or the observation in early stage lung cancer has gone from 22% in 2004 to just 10% in 2017. It has decreased in half over that time period. And when you look at things associated with the receipt of curative therapy, it includes sex and where you live and living in a city and a comprehensive cancer center, but also year of diagnosis. And race has been a big part of this. And over that time period, that has gone away. When you look at what has happened in the use of radiation and surgery, we see a dramatic increase in the use of radiation therapy in early stage lung cancer. And while surgery numbers have dipped, I don't think they've dipped significantly. The difference between operating in, 78% of the patients in this space and 68% of the patients in this space, I just don't see as a big difference. When you look at age-adjusted mortality, a big difference has been made. Now, we can't credit everything to radiation oncology here in SBRT. Surgeons have gotten better. We've moved to minimally invasive procedures, sublobar resections, and actually when we look at Black populations, Medicaid expansion and the Affordable Care Act have all worked to increase access to care. But I seriously believe that SBRT has made a dramatic impact in this space. This is further shown by another National Cancer Database analysis, this time really looking at what are survivals between observation and between SBRT. And again, I shouldn't be putting up Kaplan-Meiers, but those are not close. This makes a difference. Imagine that. Treating cancer actually helps. And the impact of SBRT in these populations are nicely shown with these hazard ratios, those with higher stages, those with more comorbidities, recent years, and advanced age. We are making a big impact by adding SBRT to our treatment armamentarium. Here's work, we have 100 trials like this from the United States, but here's a very recent one out of Korea saying, okay, now if we look at, SBRT versus sublobar resection, of course, surgery is better. It is, but they're not the same populations. These are not existing in the same populations. So what if we just look at the older patients and those with poor lung function? Suddenly, all of that difference goes away. And these are very equivalent treatments with very equivalent results when you look at patients over 75 or those over 70 with poor lung function. Okay, so what's in it for me? What does this mean to surgeons and surgical populations? So now I'm going to go over two studies which really looked at how the SBRT has improved surgical outcomes during these same periods. So again, NCDB work looking at the number of, or the percentage of programs that treat at least 17% of their early stage disease with radiation. That was kind of the median number, and they picked that as, this means you're a good program or a high volume program. And that has grown steadily in the United States, again, between 2008 and 2017. More and more programs are doing a lot of this. Then they also looked at SBRT use, surgery use, and the ratio over that time. And lo and behold, that blue line, over this period, surgery has continued to increase. We're not doing fewer cases. The total percentage of early stage, yes, we're doing slightly less, but we are still operating. No surgeons out on the corner with signs. We all have jobs and we're doing just fine, even though we see a dramatic uptake in SBRT use. Oops, I don't know what happened there. But this was very interesting to me. So this group looked and they kind of divided all these programs and institutions up. They looked at high volume and low volume surgical programs, and then high volume and low volume SBRT programs. And if you were a high volume surgical program, you did 40 lobectomies a year, it didn't really matter if you had SBRT or not as part of your program. But if you were a low volume center, adding SBRT improved not only your short-term morbidity and mortality related to your procedure, you also improved overall survival in your patients. You picked better patients, and the patients as a whole did better. So this is kind of how I think we all thought high-risk early stage looked like. There was operative and non-operative and this giant gray zone in the middle that we would all argue over. And SBRT was going to come in and take it all. And this made surgeons nervous. When the reality is, I think this is what it is. I think that group that we are ambiguous about or don't know, the gray zone between what's operative and non-operative, I think it's very slim. And I think that's one reason a lot of these randomized trials couldn't recruit, because that's just not a lot of patients. I've been doing this for 20 years. I've been at 3 institutions. I have worked with a lot of radiation oncologists. And I would say I probably share at least 3 patients a month with my radiation oncologist. They see both of us and we make a decision. And we rarely disagree. We do. There are patients where we say, I don't know. But it is rare. Otherwise, I see a patient, they see a patient, and we agree. We have the same answer. This patient's surgical. This patient's not surgical. This patient would do way better with SBRT. I think the middle ground is very small. And the reality is, I think the majority of SBRT patients are patients that surgeons want no part of. So my take homes on my argument is that local tumor control between SBRT and surgery are quite similar. And I think that the decreased survival is really related to, comorbidities and distant relapse. I think the adoption of SBRT has resulted in significant reductions in observation and age-related mortality in the United States, and we have really good data for this. I think that SBRT and surgery target very different populations. They may all have stage 1 disease, but I don't think they're same. And I think we have evidence that SBRT use does improve institutional surgical outcomes. I think this is clearly a place where a rising tide lifts all boats, and that adding another strong treatment to your program only makes survival better for everybody. Thank you.